All right, so if that last talk was semi-dense, this is more dense. So we're going to try to power through. Here are my deep thoughts on sinus anatomy. How should we learn sinus anatomy? Everyone, including myself, has to study anatomic diagrams and CT scan after CT scan, learn the boundaries, learn all the structures around the sinuses, read 100 papers, for sure, and I am a strong advocate for that. But I do think another level of depth that we should all try to strive for is envision what those structures you're studying are, what they're going to look like endoscopically. I think it's very helpful. So here's just an example. Look at it. If you're on call and you see a trauma patient, there were times where I would just say, you know what, I'm just going to take a look at the sinuses. And yes, I'm a rhinology dork, but still. So let's just say I envision, okay, there's the middle turbinate. What's that going to look like endoscopically? It'd be great if you start seeing this in your head when you look at that CT scan. It just helps you intraoperatively predict where things are. So you can also learn it based on how you encounter it during surgery. And that's what that's how I've structured this talk from maxillary through frontal. Think about the complications that can occur if you damage a given anatomic structure, and that'll really help you hone in both the anatomy, thinking about surgery, thinking about problems with surgery. It's just a better, all-encompassing way to think about anatomy. All right, and that's the end of deep thoughts. So let's dive right into the maxillary sinus. First one, we're usually open during sinus surgery. So in order to do maxillary sinus surgery, you must master the relationships of the middle meatus. To do that, you really should have this diagram in your head every time you look at a nose. Okay, this is from Bolger's anatomy chapter. It's an excellent source. And so the middle meatus, if we put a scope in the right nasal cavity, the inlet to the middle meatus is the space between the middle turbinate medially and the lacrimal system, or nasolacrimal duct, shown right here endoscopically. As you go through that inlet, if you will, the first lamella that you encounter, the first thing along the lateral aspect of the middle meatus, is the uncinate process. There's, yes, a structure right behind that in pretty much everyone, and I use this picture because it's very small, but it's still something between the uncinate and the middle turbinate. That's the ethmoid bulla. There's the famous two-dimensional line, imaginary line, if you will, between the uncinate process and the ethmoid bulla. It's the hiatus semilunaris. Then there's the three-dimensional space lateral to the hiatus semilunaris. It's the ethmoid infundibulum. This has not been talked about as much because I don't think it has as much surgical pertinence as maybe they thought when they first did anatomic studies back in the 80s and 90s. But yes, the maxillary will run through it, frontal sometimes will drain into it, but I don't think it helps you surgically to know a whole lot about the infundibulum. The basal lamella is just the oblique portion of the middle turbinate. So if you're ever confused what's bulla, what's basal lamella, just follow the vertical portion all the way back, and you can see that this is continuous with that. All right, so there's your middle meatus and the anatomy that you must know in order to perform a maxillary antrostomy. Okay, now the next sort of thought process that goes through your head when you're doing a maxillary antrostomy is uncinectomy and identifying the maxillary ostium. Okay, and I think we all know just by word of mouth where the ostium typically is located, but I like this original paper that was pretty awesome. I mean, they did a lot of analysis here. So yes, it's located in the inferior third or half of the ethmoid infundibulum. If you read older anatomy papers, if you actually go through and read this paper, which I did 5 years ago before our first dissection lab, what they found was that yes, 68% were in the inferior third, but 94% were in the inferior half. So it's just funny, sort of, to me, because the anatomy review papers out there will often say the inferior third. I think it's more helpful for you to know that in the inferior half of that infundibulum, you're going to find the ostium. Okay, and so if we use, again, trying to think of things endoscopically, this is approximately where you're going to find it. All right, and so this is the uncinate process, mid portion here. And so, yes, that is the endoscopic relationship. But what if we look at from the orientation of the sinus itself? Well, the maxillary ostium is actually in the supramedial wall and a little posterior along that wall. And so there's actually a lot of space below the natural ostium. I don't know. When I look at it endoscopically, I don't always think about how much maxillary sinus is below me there. Okay, so when we're doing this, I really like Raj Sindwani's paper from 2005. I suggest everybody look at it. Nicely done cadaver study. Whoops. Oh, that was weird. The maxillary line is this curvilinear line from the middle turbinate axilla along the lateral wall to the dorsal aspect of the inferior turbinate. And what they showed is that the uncinate process lies posterior to this in nearly all cases. The lacrimal system is anterior to it in nearly all cases. And so sometimes you have funky middle meatal anatomy. The uncinate might be everted or distorted. And so if you find this maxillary line, you can be confident that the tissue behind it is probably uncinate. Okay? And then, consistent with that older study from the 80s, the ostium is at or below the midpoint of this maxillary line. And I think this is a very surgeon-friendly line, so that's helpful. Okay, what is learning about the middle meatus and maxillary if we don't hammer home this idea of the maxillary hiatus and fontanelles? The maxillary hiatus, it's the lateral wall of the middle meatus. This is the space from the nasolacrimal duct, which in this location is surrounded by the frontal process of the maxilla, and it goes back to the palatine bone. That means that, the uncinate process divides the maxillary hiatus into anterior and posterior fontanelles. The fontanelles are where there's no bone, mucosa on mucosa. Within these fontanelles, you can have anterior and or posterior accessory maxillary ostia. And this is a cool picture. I saw a patient in clinic and had to record it because they had both, which is not that common. But in general, posterior accessory ostia are more common. Papers will say 20 to 25% of people. It's not really a big deal at all. They don't inherently mean pathology. They have some surgical implications that we'll talk about. I found this diagram or I guess cadaver picture from years past, and it's really nice actually. So this is a left maxillary hiatus, all right? Frontal process of the maxilla, palatine bone. These spaces are divided by the uncinate process, and so you have your posterior fontanelle. Again, there's no bone there. Anterior fontanelle, no bone. And these are going to be variable between patients because the uncinate bone's a variably developed bone. So again, you can have these accessory fontanelles in either of these locations based on embryologic fusion planes and such. Now, what are the surgical implications of this? If you're going to open a maxillary, you should open all the accessory ostia and connect them to the natural ostium during antrostomy, or you can have this happen. So here's a 70-degree scope view of somebody who had sinus surgery. A little bit of the uncinate was left. I'm guessing nobody put a 70-degree scope on to look at this anterior superior corner because this should have been removed during sinus surgery. Now, admittedly, you can do that and still have bad luck and get this funky scar band or webbing here and a little pinpoint opening. But if you're looking for it and you have a 70-degree scope in the office, you can very easily take down that scar band and not develop this problem. So you need to be aware of it. Okay, we've talked about how, or the anatomy that's going to allow you to open a maxillary, do a maxillary antrostomy. That's great for routine sinus surgery. However, you also should be aware, you're in training, you should learn about the anatomy around this so that you can do extended approaches. And so what am I talking about? All the things that are around in all dimensions in this picture. Okay, and that's what we're going to go through right now. So start with the roof, probably the more basic surrounding anatomy. So we've got the infraorbital nerve, we all know, runs along the orbital floor, but it does take a variable course as it courses through the floor, or above or within the floor. So you can sometimes branch downward and actually run through the sinus. Sometimes it'll run flush to the orbital rim and then down the maxilla. And so you just want to make note of that sometimes. Here's a really nice view of this patient actually. 70-degree view, post-operative. You can see infraorbital nerve. This is the orbital floor. It actually has two branches that go through the sinus. So yeah, you just want to be careful if you're ever doing something like a Denker's approach for a tumor. You don't just go and bag these nerves unnecessarily. Okay, other thing along the maxillary roof, you can have infraorbital cells, or the classic Haller cell. Okay, here's an example of one. I think the important thing to realize are two things. Number one, it's based on the orbital floor, and so if you go through its roof, you'll be in the orbit. Number two, if it's big enough, it will obstruct your maxillary sinus outflow tract. And performing a maxillary in this case, imagine removing this uncinate clip, 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 and then you're going to see a wall of stuff. Okay, and so hopefully you will have recognized this pre-op and realize that you have to go through that and it's not orbit, or maybe you'll have image nav and you'll be saved. But good to recognize this pre-op. Okay, and of course the topic near and dear to everyone's heart, not just mine, right, are the tooth roots. So the floor of the maxillary sinus are formed by teeth and the alveolar bone of the maxilla. Mostly molars, some premolars. Every once in a while you get a funky canine that's poking up in there. And so yes, it can cause odontogenic sinusitis. So here's just an example of tooth root with a periapical lesion, most likely an abscess, that has caused an odontogenic sinusitis. This is an example of actually just a really bad tooth with endodontic and periodontal disease. It's not an oriental fistula, but either way it's causing a nasty sinusitis that was pouring pus out of his nose. So watch the tooth roots, look at them, I would argue, on almost every scan, but especially if you see maxillary opacification. Okay, let's move on to the medial wall. A lot of action here, actually not a whole lot, but important to know. First off, the inferior turbinate inserts into the medial wall there. This is the medial wall. In between is the inferior meatus, where the nasolacrimal duct drains. Okay, so we're going to do some endoscopic correlations here. So here's a patient that came to me. This was an intraoperative view of somebody who had surgery before. So obviously had a partial turbinate resection here, inferior turbinate. Here's your middle turbinate. There's a remainder of uncinate process, which should have been removed during sinus surgery. They had a maxillary enterostomy done here, but I believe, if I recall correctly, they only opened up the posterior fontanelle. And then somebody did an inferior meatal enterostomy here as well. So again, these are the relationships to think about. We're in the inferior meatus here. You're not seeing the nasolacrimal duct orifice, but I'm going to show you that in another slide. Just so everyone knows, Dr. Yu's going to talk about this, but this is essentially what you're removing during a medial maxillectomy. Turbinate, medial wall, sometimes cutting the nasolacrimal duct. Okay, so let's think about the nasolacrimal duct and how it relates to a maxillary enterostomy, because I think that it's sort of scary in training when you're taking down the uncinate. You're always worried you're going to go too far forward. And so that's why I put these slides together. So here's a pediatric backbiter in the middle meatus. We've gone through the hiatus semilunaris. We're about to take some bites of the uncinate. As we come forward, we start everting that uncinate, and you're going to start to see a groove forming here on its insertion into the lacrimal bone. And this is sort of where the lacrimal system is going to be found. The nice thing low down, where we start our cuts, is that this is usually frontal process of maxilla, and it's pretty thick bone. That's why we say when you reach thicker bone, stop. So this is where you're going to see it. The reality, and I want you guys to play around with this, take bites forward and injure the lacrimal system in the lab. There's actually a little more love here than we all want to admit. There's a little more space here. You still want to be careful, but that bone does protect you technically. Okay, so now the posterior wall, some interesting anatomy here. So here's an axial scan. This is the posterior wall of the maxillary sinus. We're going to look at it from medial to lateral. So this is right behind the palatine bone, which is right around where my cursor is. This is the sphenopalatine foramen where the artery and some of the nerves run. Okay, so endoscopic correlation, right? That's what we're going to do in our heads. I've done a maxillary enterostomy to the palatine bone. You get this little outpouching of the palatine bone called the crista ethmoidalis. The thing behind it is usually a neurovascular bundle, and if you tease away all the periosteal fibers and other things, you can get it looking really pretty like that. And that's the sphenopalatine artery. So during a sphenopalatine ligation, we typically take down some of this crista ethmoidalis to get more exposure to the artery so it's easier to ligate. Now, if we go out further lateral, taking down the medial wall of the posterior wall, medial aspect of the posterior wall of the maxillary, we're going to hit on this scan here, this little space that looks bigger on scope. It's the pterygopalatine fossa. A lot of structures in there we're not going to go into today. We'll do that more in our skull-based dissection. Okay, lateral to this, okay, and if you want to look at this diagram or this CT, this is the lateral pterygoid plate. It forms an imaginary line here called the pterygomaxillary fissure. Lateral to that fissure is the infratemporal fossa. This fossa has all the muscles, or a lot of the muscles of mastication, much larger space. We don't get in there very often, but every once in a while we'll have a tumor out there, or some infections. All right, we'll take a slight breath. There's a lot of maxillary there. We're going to now do the ethmoid, which is a lot easier to go through. Anterior ethmoid sinus. Yes, we can think of the ethmoids as sort of a box, all right? And so it's important to know the boundaries because during sinus surgery, as Dr. Yu will talk about, we're removing all the little partitions to these boundaries. So middle turbinate medially, ethmoid roof or fovea ethmoidalis superiorly, lamina papyracea laterally, basal lamella of the middle turbinate posteriorly. That's the boundary between anterior and posterior ethmoids. And the one name cell, you're going to see that amongst all these boundaries, I throw in a cell or two that I think is worth knowing the name for. In general, I think boundaries are more important to learn. But yes, we should all know what the ethmoid bulla is because it's in pretty much everyone. And the, whoops, can't go back. But the lateral aspect, the lateral wall of the ethmoid bulla is the lamina. Okay, I think this is a really important slide. In training, I think reading about the middle turbinate is pretty confusing. And until you do a number of surgeries, and honestly, until you resect it a few times, understanding the anatomy is tricky. So it's got three portions. And I really like this diagram. It's from a Bulger paper in 1995. So it's not in his anatomy chapter that I've given everyone, but you can search for it. It's a nice shot of the horizontal portion. Okay, so you have the vertical portion anteriorly, the oblique portion in the mid portion, and then a posterior horizontal portion. Now time for the diagram, which I've freshened up a bit since years past. What we're going to do here is, here's the endoscopic view. The blue line refers to the medial aspect of the left middle turbinate. So we're going to flip this 90 degrees, and you as the observer are going to be standing between the septum and the middle turbinate looking at its medial aspect. So here's the end. This is a diagram, anterior portion here. All right. Vertical portion is anterior, right? What we're going to do here is focus on the insertions because I think in the literature it's tricky. So nasofrontal beak is where the vertical portion first inserts, which is going to correlate with the frontal sinus floor. Then eventually it will get back to the cribriform plate, and then it's going to swing across the skull base or the ethmoid roof until it hits the lamina. Then it's got its oblique portion that's going to run down along the lamina and eventually articulate with the palatine bone. And that's it. All right? But I do get it. It's confusing. So if everybody emails me, or I can send them this diagram so you can master this. All right. The only other thing that I mentioned before is that, yes, the basal lamella, which is the oblique portion, separates the anterior and ethmoid, or anterior and posterior ethmoid sinuses. Okay? And that, I think, is all you need to know about the middle turbinate. Resect them during the dissection today so you can get comfortable with where they insert. Okay, posterior ethmoid's quick. It's very similar to the boundaries of the anterior ethmoid, except for the superior turbinate. So the superior turbinate is the medial boundary. Fovea ethmoidalis is the superior, lamina laterally. And then I just say that the dorsal aspect of the middle turbinate is an inferior boundary. It's sort of arbitrary, but I have seen cells that reside down here. And so if you stop short and don't find the middle turbinate, sometimes you'll leave some disease there. All right. I think it's important also to appreciate terminology and the anatomy of the ethmoid skull base because there's different portions. You have the ethmoid roof, which is formed by the orbital portion of the frontal bone. So it's continuous with the orbital roof. It articulates with the cribriform plate via the lateral lamella of the cribriform plate. I've asked this before. Basically, the lateral lamella belongs to the cribriform plate. It is a lamella from the plate up to the ethmoid roof. Okay. The height of this lateral lamella corresponds to the height of the olfactory fossa where the olfactory tract runs. All right, and there's your ethmoid skull base in a nutshell. The only other thing I want to hit on with the ethmoids is the anterior ethmoid artery. I've been very happy with everyone's ability to identify the structure, but I just want to go through how we can do it in a very methodical process. So in this situation, we've scrolled past the globe on coronal bone windows. You'll find your superior oblique, your medial rectus, and you know that the artery runs between these two very reliably. Okay, I suggest everyone take down the lamina in the lab and find the medial rectus and superior oblique, and I guarantee you're going to find the artery in between. Now, the artery then courses through this outpouching of the lamina called the anterior ethmoid foramen, and that's going to then run through the anterior ethmoid canal. It can be below skull base, within skull base, or above skull base. And then it's going to penetrate through the lateral lamella of the cribriform plate. So here's sort of the course it takes. It'll run then through the olfactory fossa and then send off little branches through the cribriform plate. And that's your anterior ethmoid artery. And remember, we have to consider what things look like endoscopically. And I always give a shout out to Ayaka because I tortured her with this every year. And so I think it can be confusing. So this is a left frontal recess. Lamina, middle turb, lateral lamella of the cribriform plate. That's the supraorbital ethmoid cell. We'll go over that in a little bit. The artery runs from posterior to anterior, from lateral to medial. That is the direction it will course pretty darn reliably. Okay? So there's your endoscopic correlation. We move on now to the sphenoid. All right, so you have to know how to identify the sphenoid ostium. It's pretty much always going to be found medial to the superior turbinate. I have one case that comes to mind that was lateral, but it's pretty much always medial. That drains into the sphenoethmoid recess. What's the sphenoethmoid recess? It's the space between the superior turbinate and the septum, and then superiorly it's bounded by the cribriform plate, and then of course posteriorly the sphenoid face. This is a patient I saw in clinic that had no disease, but I've never seen a sphenoethmoid recess that beautiful, so I made sure to take a picture. All right, so here's some surgical correlation. This is what we do. Dr. Yu will talk about this more, but this is a sphenoidotomy. I'm just going to highlight anatomy. Orbital floor is over here, taking down the superior turbinate, and then pause. This is the sphenoid sinus. It's small. Well, then what is this? Yes, it's the sphenoethmoid cell or Onodi cell. Okay, it's always superior to the sphenoid proper. Remember that relationship, superior. And yes, we all have to know that the optic nerve is found along the superlateral aspect near the planum of that cell. Okay, so here's that picture. And so you've done your posterior ethmoidectomy, and you know, I know if you're not paying attention to your preoperative CT, you could do something really bad and go bite that, but I think if you didn't have a ledge behind it, nobody would go bite it anyways, but it's still good to know that you're really close to that, so don't go cauterizing around it. But here's the other reason to understand the relationship of a sphenoethmoid cell, okay? And I quote David Kennedy here. This is not, I always say, I did not make this up, but if you're opening ethmoid cells and you're like, is that a sphenoid? Okay? Look for the floor of that cell. If you can see a floor of that cell, it's almost certainly not a sphenoid, because you have, for a real sphenoid, you have to drop down the anterior face in order to see the floor, at least with a 0-degree scope. Okay, so that's the only other thing I wanted to hit on there. All right, since we're going to be doing extended approaches, you should know we won't do a whole lot of skull base today unless you get to it, but anatomy around the sphenoid is important. Okay, dangerous stuff. So midline in the posterior walls, the sella, which has the pituitary gland. Posterior laterally, you have the optic nerve, which is along the planum. Below that, you have the tortuous course of the internal carotid artery, the cavernous portion. In between, you have what's called the optical carotid recess, variably pneumatized. And as you all know, the pneumatization is of the anterior clinoid process. Might be a board question, I'm not sure. Anterolaterally, you have the orbital apex. So when you make your nice wide sphenoidotomy here, as you get to thicker and thicker bone, that is where the orbital apex is. A lot of critical structures there. Don't go cauterizing or, biting aimlessly. Medially, you have your inner sinus septum and nasal septum articulation. Anteriorly, as you go down along the anterior face, you're going to get to the posterior septal branch of the sphenopalatine artery. Its course is variable in vertical dimension, so you could sometimes have bad luck and find it up here. Inferiorly, I think it's just important to realize the nasopharynx is right below you. So there are times where we have to drill out the sphenoid floor, and patients do fine draining right into their nasopharynx. All right, we'll take a slight breath here. We're going to finish strong with the frontal sinus and all the fun relationships. 10-second breath. Okay. So, the frontal sinus outflow tract. We're going to try to simplify this by first just saying simply, mucus drains from the frontal sinus through the frontal sinus outflow tract into or through the ethmoid cells in the nasal cavity. Simple, right? All right, well, we're going to make it a little more complex here. We need to talk about the frontal recess, because the frontal recess is where you have a bunch of anterior ethmoid cells, and the mucus is going to drain around them before getting into the nasal cavity. All right, so very important to understand the boundaries, because these are what you're going to be using when you perform a frontal sinusotomy. Anteriorly, you have the nasofrontal beak, which is variably pneumatized by anterior ethmoid cells. Here's an example of a large agar cell. Posteriorly, you have the ethmoid bulla, could have a lamella, or it could be totally pneumatized to the skull base. Anterior ethmoid artery can be a boundary. It's kind of variable and sometimes difficult to identify, so I don't think it's as helpful. And then, of course, posterior superiorly, you have this skull base. Again, it's all anterior to the bulla, and, well, actually anterior to the middle turbinate too, but that's not shown in this picture. Okay, so then superiorly, you have the hourglass waist of the internal frontal ostium, which is the narrowest dimension between the nasofrontal beak and the skull base. That's a simple way to think of it. All right, and then medial and lateral are the friendly lamina and middle turbinate. So within this box is where you perform a frontal draft 2A frontal sinusotomy, which Dr. Yu is going to talk about. Okay, so boundaries are easier to, I think, comprehend. I think the trickier part people run into is when you think about all these little cells and partitions within the frontal recess. They're all anterior ethmoid air cells, but nomenclature has been notoriously confusing and variable. I think in recent years there's been a lot of progress there. And so I've been teaching more of the European position paper in 2014, looking at cells as anterior, posterior, medial, or lateral groups of cells. And these are named based on where they're based. Then they have free walls that form the actual frontal sinus outflow tract, and that is what you're going to be probing or using biting instruments or curettes to fracture and remove during a frontal sinusotomy to the boundaries. Okay, and of course those boundaries are the bases of these cells. So study the configuration preoperatively in the lab today. Look at the frontal recess. We're going to do a pre-op CT eval later. And it does make it a little easier to find the outflow tract, but honestly, frontals can be tricky. Even if you study it for a day, you might still be surprised by an outflow tract. All right, so let's go through how we name these cells. Anterior cells are based along either the nasofrontal beak, anterior table of the frontal sinus, or a frontal process of the maxilla. They may also have a continuation and a base onto the lateral, out laterally along the lamina, like I said, the frontal process of the maxilla, but they also have that anterior base to them. That means, first we'll talk about these name cells. So these are the classic Kuhn classifications for anterior cells. Okay, you have your agar, which is one cell. We don't talk about this as much anymore, but I think you'll still need to learn it at some point. So type 1 cells are above the agar. Type 2 cells are 2 cells above it. Type 3 cell is important to understand because it's an anterior ethmoid cell where its cap will pneumatize up into the frontal sinus proper. Okay, and then the type 4 cell. Okay, so here's what I find interesting about this. So that's an example of a type 3 cell, by the way. But here's the deal with type 4 cells. This came up in an imaging conference recently. We call it asked. This is what that patient had. Call it if you're watching. But it doesn't technically fit the criteria for a type 4 cell from papers that I've read, because a type 4 cell, all of its walls should be its own. Okay, and I don't want to get caught up on this too much because, like we said, it doesn't matter that much as long as you remove the free walls. But this, according to newer standards, I believe would be considered a lateral cell because it's based on lamina and orbital roof. Again, we could probably deliberate this for a while. I just wanted to point that out. Okay, so I think a key point, though, is, yes, they're based anteriorly. Their free walls will form the outflow tract. So on an anterior cell, the free wall is going to be posterior. That's where you're going to look for your outflow tract. And there's similar themes throughout the rest of these slides. So posterior cell, they're based on the skull base, anterior to the middle turbinate. There is a name cell I think is important for you guys to know with posterior cells, and that is the supraorbital ethmoid cell. This is a nice endoscopic view showing the anterior ethmoid artery. The next pneumatization above it is often a supraorbital ethmoid if it's present. Otherwise, it'll be the frontal. But the supraorbital ethmoid will pneumatize below and out lateral to the frontal sinus. So if you ever looked at trauma scans, maybe when you're on call, you might say, oh my gosh, I didn't know people had 4 frontal sinuses. But actually, the lateral one will be your supraorbital ethmoid. The medial ones will be your frontals. Okay, same rule goes here. The frontal outflow tract is anterior to the posterior cells. Okay, so if you know that you have posterior cells preoperatively when you evaluate your CT scan, you've opened up into the frontal outflow tract. If you didn't take any cells down after you got into the frontal outflow tract posteriorly, you may still have some to take. And that's sometimes one reason people have these narrow frontal outflow tracts. They think they did as much as they could, but it's possible they didn't. Okay, a medial cell, same idea here. It's going to drain unilaterally generally into one of the frontal recesses. This is from Cassiano's textbook. There's a frontal medial cell here. So that means the outflow tract will be identified lateral to the free walls of that cell. Lateral cells are pretty uncommon. Honestly, the one that I presented in that imaging conference was one of the first ones I had seen. I think this is consistent with one. It's based solely off the lamina or orbital roof with no attachment to the nasofrontal beak or posterior table. Again, the main thing to take from this is the outflow tract that you have to identify and the free walls that you have to remove are going to be found medial to that base. All right, let's summarize frontal anatomy. Bony partitions originate from the bony boundaries of the frontal recess. Anterior, posterior, medial, and lateral cells are easier to comprehend, I think. They're named based on where they're based from those frontal recess boundaries. The outflow tracts will be located, or the outflow tract will be located between their free walls. The Kuhn classification only accounts for the anterior cells. A frontal sinusotomy involves removing all the bony partitions down to the boundaries of the frontal recess. Here's a cadaver I did. Lamina, nasofrontal beak, middle turbinate, skull base, and there's your anterior ethmoid artery. We're going to take a break. But next up, the infamous Dr. Yu will talk about surgery. Thank you. Any questions?
None from the resident room. Thanks, Dr. Fred.
Cool.